thanks very much, Marcel. It is a particular pleasure to be able to speak to you this morning. My father actually received his degree in medicine from the University of Basel, which is why I was born in Basel many years ago, but always fun to come back. So I'm going to speak about the second generation integrase strand transfer inhibitors and give you some of the clinical trials data that form the basis of the treatment guidelines that Milos just reviewed for you. And then I'll go quickly through those data because they all look very much alike and I think are well known to you, and spend a little bit more time then speaking about some of the more recent concerns around adverse effects of, or potential adverse effects of these regimens, and then say a word about resistance. These are my disclosures. So I'll talk about dolutegravir and bictegravir. I'll say a bit about two-drug regimens because there are now data for the use of two-drug regimens as initial therapy. As I mentioned, I'll review some of the new data on toxicities, say a few words about resistance, and then summarize. So this slide is not meant to help you learn the chemical structures, but just to emphasize that what we speak about as first generation integrase inhibitors are raltegravir and elvitegravir, and we now have three second generation INSTIs, dolutegravir, bictegravir, and soon to be approved cabotegravir. So to speak first about dolutegravir, there are a number of trials that have compared triple drug regimens using dolutegravir in comparison to what had previously been standard of care, either non-nucleoside RT inhibitor-based or protease inhibitor-based regimens, as well as comparisons to the first generation NNRTI raltegravir. And this slide shows the data from the single study that compared dolutegravir to efavirenz. These are the 144-week data. So the primary endpoint was at week 48, and you can see that dolutegravir was superior to efavirenz at that time point, and although with dropout from the study over time, the numbers decline slightly, that difference with efavirenz persists. And that difference is driven almost entirely by the better tolerability of dolutegravir as compared to efavirenz. When compared to raltegravir, these are now the 96-week data. You see that they're really quite similar with after 2 years on study, 80% of the participants remaining in study and virologically suppressed. There are small differences in serum creatinine that occur. This is not because of any renal toxicity, but because dolutegravir, like bictegravir and cobicistat, has an effect on tubular secretion of creatinine. The precise transporter that's inhibited is different for the integrase inhibitors compared to cobicistat, but the net effect is the same, and that is a modest increase in serum creatinine, which then is reflected as a modest decrease in the estimated glomerular filtration rate, but no actual toxicity, no damage to the glomerulus. And if you do iodohexol clearance and calculate a formal GFR, there's absolutely no difference. It just makes things slightly confusing clinically, especially if a patient is at the margin of renal, stage 1 renal insufficiency. Compared to dolutegravir, darunavir was again superior. These are once more the 96-week data, and you can see here about 80% suppression and persistence in the trial for the dolutegravir participants compared to about 70% for the ritonavir-boosted darunavir. This was the once-daily dose of darunavir in treatment-naive people. And again, the difference is largely driven by differences in tolerability, not so much intrinsic antiviral activity. Well, what about bictegravir? Bictegravir is only available as the fixed-dose combination with FTC and TAF, and there are two trials in first-line therapy, one comparing to another fixed-dose regimen, this one of dolutegravir with 3TC and abacavir, and here you can see that the trials data show really quite comparable rates of suppression. This is by FDA snapshot analysis. The majority of the participants who don't qualify as suppressed have missing data. The number of actual virologic failures is tiny, and you can see here that in the full analysis that the comparison meets the non-inferiority margin that was pre-specified, and so bictegravir and dolutegravir, given as fixed-dose combinations, are really indistinguishable from one another. The other trial compared bictegravir to dolutegravir given with the same nucleoside backbone, FTC and TAF. Of course, for dolutegravir, that was 2 tablets as compared to the single tablet regimen. And once again, you can see here the blue color shows the data for bictegravir and the red for dolutegravir, and the results are nearly identical. Once more, the majority of the participants who are not suppressed have missing, who are not counted as suppressed have missing data. Very small numbers of people who had protocol-defined virologic failure. Once again, in the full data set, the study meets the non-inferiority endpoint, and the lighter colored bars are the per protocol analysis, and these are, again, the 96-week data. Well, what about 2-drug regimens? The data we have here are for dolutegravir and 3TC. These are the 96-week data from the Gemini trial, pooling the 2 Gemini studies together as presented this summer in Mexico City by Pedro Khan, who really started the interest in dolutegravir 3TC with his pilot paddle study several years ago. And in this study, participants received either dolutegravir plus 3TC or dolutegravir plus TDF FTC. The study was initiated before availability of TAF. And so nobody was getting a single tablet regimen in this trial. But what you can see is that the outcomes at 96 weeks are nearly identical, with a difference of only 3.5% that meets the non-inferiority margin. The primary endpoint at week 48 also met the non-inferiority margin, and now this combination is available as a fixed drug combination of dolutegravir and 3TC and is approved in the United States for first-line therapy. It has not yet made it into any of the guidelines. Now, I'm going to cheat a tiny bit, even though we're supposed to be talking about first-line therapy. The FLAIR study, which looked at long-acting cabotegravir administered together with long-acting rilpivirine by intramuscular injection, started with treatment-naive patients, but it didn't actually start with injectable therapy as first line. It first suppressed participants on a triple drug regimen of dolutegravir, abacavir, and 3TC, and then those who were suppressed after 20 weeks of study could be randomized to either continue on their oral regimen or to switch to an oral lead-in of cabotegravir and rilpivirine for 4 weeks, really in order to assure that there was no hypersensitivity or other toxicity of these drugs before beginning the long-acting therapy. And then for the next period, these participants who were randomized to the injectable arm received monthly injections of cabotegravir and rilpivirine. These were 3 ml injections given monthly in the buttocks, and then after 96 weeks, the people in the oral arm could roll over to an extension phase in the with injection. The primary endpoint was at week 48, and these are the 48-week data showing the FDA snapshot analysis. Now here, the analysis is slightly complicated because the participants were suppressed on the triple drug regimen when they switched to the 2-drug injectable. This study really counts as a switch study, and so it uses the new, more rigorous FDA analysis that counts treatment failures as the primary endpoint. And so you can see that essentially 2 and 2.5% of the participants experienced failure, and therefore there's a tiny difference, and that easily meets the non-inferiority margin for the primary endpoint. The secondary endpoint was the percent who were suppressed, and these numbers are virtually identical, 93.6 and 0.3%, and again, meeting the non-inferiority endpoint. So although you can't, once this regimen is approved, you couldn't initiate somebody on injectable cabotegravir and rilpivirine, you could rapidly transition people to that regimen. Well, what about the adverse events associated with second-generation integrase strand transfer inhibitors? Both drugs are generally well tolerated. Both drugs, I only showed you the data for dolutegravir, but the same would apply for bictegravir. Both drugs have a modest effect, not a clinically significant effect on tubular secretion of creatinine, and therefore cause an artifactual reduction in estimated GFR without any renal pathology. As Milos discussed already, a dose adjustment is required when dolutegravir is administered with rifampicin. One cannot dose adjust bictegravir for administration with rifampicin, which is a bit of an issue for the use of that regimen. And then there are concerns about possible neural tube defects with dolutegravir, and I'll show you those data in some detail, and emerging concerns around weight gain. Well, what about weight gain? There were anecdotal reports about patients having profound increases in weight on integrase inhibitor regimens that really got a fair bit of attention at CROI this past winter when data were presented from an analysis of NA Accord that looked at people receiving first-line therapy with a variety of different regimens, and you can see that compared to the non-nucleoside RT inhibitors, the protease inhibitors and integrase strand transfer inhibitors were associated with much greater weight gain, with about a 6 kilo increase on average for people on INSTIs compared to about a 4 kilo increase for the non-nukes. And what you notice in these curves is that there's an initial rapid increase, which presumably reflects some return to health of people who have been ill for some time with HIV infection, and many of these patients were initially treated long before the guidelines for immediate initiation of antiretroviral therapy, regardless of CD4 count, came into being. But there's also a continued gradual increase in weight that persists over time, although those slopes look relatively parallel. Now, if you break out the integrase inhibitor group into the different drugs, what you see is that there's a much greater increase with dolutegravir compared to raltegravir or elvitegravir, with about a 6 kilo weight gain for dolutegravir compared to 5 and 4 kilos for the older drugs. So this seems to be potentially a concerning signal about a greater weight gain with dolutegravir. And that concern was heightened a year ago with the presentation of the NAMSAL data at Glasgow, and then again with its publication this summer, showing that in men and women who received a TDF 3TC dolutegravir regimen compared to efavirenz with the same nucleoside backbone, the proportion of participants who became obese in the study was 14% in the dolutegravir arm compared to 2% for men, and 12% versus 7% in women. And then, as Francois Venter presented in the advanced study, and I apologize, these lines are really quite light. This is taken directly from the New England Journal publication, and the colors and the width don't project as well as they might. But what you can see is, to everybody's great surprise, so there was greater weight gain with dolutegravir compared to efavirenz, but what was really striking was when people were receiving dolutegravir with TAF as opposed to dolutegravir with TDF, there was a much greater weight gain, and this is about a 6.5 kilo gain. You can't quite see those numbers. And the increase was much greater in women compared to men. Now, this study was done in South Africa, really in the Johannesburg area of South Africa. So again, these data would seem to be concerning for some signal, not only for dolutegravir, but for TAF. But the mechanism is not understood. understood, and there's an alternative potential explanation, which is that other antiretroviral regimens perhaps are appetite suppressing or associated with gastrointestinal toxicities that limit the weight gain that you might see if in normal healthy people in the absence of any HIV infection and in the absence of therapy. Remember that on average, people are gaining a kilo a year because of our current diet. And this most recent analysis published by my colleague Paul Sachs just a couple of weeks ago in Clinical Infectious Diseases really questions whether we are in fact looking at drug-specific effects or at more general effects. And I'll take you through the data here because I think they really help to place the earlier data from Namzal and Advance and the NA Accord study in context. So here you look just at weight this column here is the change in weight, and this column is the absolute increase in weight. And what you can see is that there is an increase, a greater increase in weight, as well as greater absolute weight over time in people receiving integrase inhibitors compared to the PIs and the non-nucleoside RT inhibitors. But recall that with the exception of elvitegravir, none of the integrase inhibitors regimens have a booster, and of course there are big differences in tolerability between efavirenz and the integrase inhibitors. When you then look at the integrase inhibitors by themselves, there's no difference between bictegravir and dolutegravir. They are both associated with greater weight gain than with the cobicistat-boosted elvitegravir, whether you look at the overall change in weight or you look at absolute weight. And again, we're seeing about 4 kilo increases. Oops, I'm sorry. How do I go back? I was using the wrong button here. Yeah, so as Paul very nicely discusses in his article, we really have to think about what may be the potential causes of these increases in weight. Is this actually mechanism driven? Is there some off-target effect of the integrase inhibitors where they're interfering or modulating the effects of appetite hormones like leptin and ghrelin, or is this really some other effect that because these are better tolerated regimens, people are simply eating more than they would on other regimens? And there's really no understanding of how TAF is associated with greater weight gain than TDF, except that other studies and studies in seronegative people in some of the PrEP studies have shown an initial decrease in weight on TDF because of mild GI intolerance. And so again, that may be playing into this. And I think it's going to be important to monitor. The other thing we really don't know is if somebody has dramatic weight gain on an integrase inhibitor and you switch them to an alternative regimen, do you see a loss of that excess weight? There's a study that Paul and colleagues are working on through the AIDS Clinical Trials Group now to switch people suppressed on dolutegravir to a doravirine-containing regimen, and we'll see. That will be confounded, though, because that will have a TDF component, and if TDF is appetite suppressing, then we might indeed see a reduction in weight, not because of the change from an integrase inhibitor to a non-nuc, but because of the change from potentially from a TAF regimen to a TDF regimen. Well, what about neural tube defects? The story here is somewhat ironic. Botswana had been way out in front in the rollout of dolutegravir as a replacement for efavirenz. And in fact, it had been Botswana that collected data to suggest that the earlier concerns around potential neural tube defects with efavirenz that had been seen in non-human primates and where there had been some case reports in humans were probably overstating the risks of efavirenz to the developing embryo and fetus. And because they had such widespread use of efavirenz, they were able to collect data across the country. And then as the rollout to dolutegravir was occurring, Roger Shapiro had received a grant from the NIH to collect systematic data on pregnancy outcomes. And the initial intent was to collect those data on efavirenz, and then they were able to collect data on dolutegravir as well. So about a year and a half ago now, as the WHO was preparing for the global rollout of dolutegravir as the preferred first-line regimen, they asked Roger and Rebecca Zasch to do an interim analysis, an unplanned interim look at their data so that they would have safety data on dolutegravir in pregnancy. And to everybody's great surprise, what they found was that there was an excess of neural tube defects in people, women, the babies of women who had received dolutegravir during the conception period, so at the time they were becoming pregnant or in the first few weeks of pregnancy, compared to women who never received dolutegravir or those who received dolutegravir later in pregnancy. And what you can see is that the rate was 0.94%, compared to 0.12 for any non-dolutegravir regimen at conception, 0.05 for efavirenz, and 0 for people who started dolutegravir later. And this was a statistically significant difference. This was based on 4 babies born with neural tube defects out of more than 400 births, compared to 0 out of nearly 3,000 births for those who started dolutegravir later. So this, of course, generated substantial concern and led to this extraordinary effort in Botswana, which is really a credit both to the health infrastructure in Botswana as well as to Roger and Rebecca and the Tsapamo study group. They were able to expand their surveillance across the entire country so that something like 70% of all live births in Botswana, for all births in Botswana, of women who had initiated antiretroviral therapy prior to the availability of the information about this toxicity could be collected. And so they did this and then reanalyzed their data. And what you can see is that the rates of neural tube defects decreased dramatically from 0.94 to 0.3, whereas the other rates remained essentially stable. So they had only a single additional neural tube defect in the subsequent 9 months of data collection. This remained statistically significantly greater than the other regimens, but it's really a much lower rate overall. In addition, the Brazilian government, the health ministry in Brazil, collected data on nearly 1,500 births, and they saw no neural tube defects. And the incidence of those who were dolutegravir exposed was 0, with these confidence limits shown here, and in the unexposed women, likewise, was 0. And so that's out of, you can see for any dolutegravir, that was about 360 exposed women compared to 1,000 in the control group. Now, one big difference between Brazil and Botswana is that even though apparently the wheat that is imported into Botswana from South Africa is supplemented with folate, there isn't additional folate supplementation given to pregnant women, whereas it is routine in Brazil to supplement with folate pregnant women. Whoops, that slide didn't. I get these buttons wrong here. Okay, so just to summarize the safety concerns, so weight gain is seen with all members of the class. There's a highly heterogeneous effect with apparently greater effects in some women compared to men. We really don't understand the mechanism, and whether TAF really plays a synergistic role in this weight gain or not is something that needs to be sorted out. In terms of the neural tube defects, there's a residual statistically significant risk with dolutegravir in the Tsapamo study, but no association of periconception dolutegravir use and these defects in Brazil. The WHO guidelines now recommend TLD in all populations, but the US guidelines continue to hedge on this, as do the European guidelines. Just very quickly, a few words about resistance to these drugs. Dolutegravir and bictegravir have an entirely overlapping pattern of resistance mutations, which are similar to those of the first generation inhibitors, but you need more of these mutations to generate high level resistance to the second generation drugs. Importantly, in studies of dolutegravir and bictegravir, there has not been any resistance observed to either of these integrase inhibitors at the time of virologic failure. These are data from the dolutegravir and bictegravir FTC TAF study. And these are the data with the abacavir 3TC comparator. And again, you can see no resistance at all. That doesn't mean you can't generate resistance. This report from Rafi Landowitz and colleagues from UCLA showed that one person who had a primary infection with a very high virus load, over 1 million copies, who started on a TDF FTC dolutegravir regimen, had an initial decline and then a modest rebound, and at that time had evidence of some integrase inhibitor resistance mutations, and then during further follow-up, after darunavir was added, showed emergence of classic mutations at the 148 position. In addition, in the cabotegravir studies, particularly in participants from Russia, who actually, this slide is incorrect. These are not A1 subtypes, these are A6 subtypes, but the 3 people who had virologic failure in FLAIR were all participants with the A6 subtype virus, all had polymorphism at position 74 in integrase prior to the study, and all 3 developed additional integrase inhibitor mutations at position 140 or 148. Whether this polymorphism potentiates the emergence of resistance or not is something that is under active study. So to conclude, resistance to dolutegravir and bictegravir it has not been observed in trials of treatment-naive participants, but it can occur. Dolutegravir resistance can emerge in treatment-experienced patients on either dual or monotherapy, which I haven't really discussed with you. Shared mutations result in cross-resistance. Dolutegravir monotherapy should be avoided at all costs. Although the barrier to resistance to both of these second-generation integrase inhibitors is high, these drugs are not foolproof, and intermittent adherence or inadequate drug exposure can increase the risk of resistance to these drugs. And with that, I'll stop, and I'm happy to take any questions.